Okay, so a very good afternoon to all the panelists and Bala sir, and to all the audience. Thank you for the opportunity, AIS. So myself, Dr. Jitendra Vidhani, and came show from the land of peace and growth, and I would be talking on Phaco in soft cataracts. So case one, 33-year-old male patient, right eye amblyopic with PSC and grade 1 cataract. Right eye vision was finger counting 3 meters. Left eye vision was 624. Left eye operated 1.5 years back. GBP consent was taken because he had amblyopia. So well-sized, good-sized rexes was done, and then the import is created, and I'm just trying to remove the excessive OVD. Hydrodissection and hydrodelineation is done, and the lens automatically pops out. So I just don't try and push it back in the bag. Because it's a soft cataract, so I would like it to stay there, and then directly I would go and emulsify it with the probe. So when you hydrodelineate it, the case becomes very simple, and after that just the cortex was remaining and it was removed, and the case was completed. Case 2, a 6-year-old female patient, diabetic and hypertensive since 10 years. Right eye was operated 1 year back. Right eye vision was 6.6. Left eye was 6.9. It was a really soft cataract, but I tried to chop it. So I was using the technique stop and chop. So initial chopping was complete. I could make a primary chop, and I could divide it into 2 heminuclei. But a little bit of cheese wiring is happening, and I'm not able to really get through the cortex because through the nucleus, because it's a really soft cataract. So then I really changed my technique and kind of shifted to trench and divide, and then I was able to divide the nucleus into much more quadrants and then emulsify it easily. Uh, 51-year-old male patient, right eye grade 1 cataract, right eye vision 624, left eye vision 618 parts. The IL power calculated was 20.5, a little bit on the myopic side. So in this case again, the initial chopping was done with stop and chop technique, and low parameters were used on the Phaco machine. The power was not there. I had kept it on 10 probably. And again in this case I was not able to chop it completely, so I shifted to trench and divide, and then I was able to divide it into multiple pieces. And once that gets separated, even if you have 2 heminuclei, then you can really emulsify it very easily. And then the epinuclear plate is removed with the probe itself. That's it, the case was done. Next case, 44 years old female patient, right eye vision was 624, left eye vision was 6.9. It seemed like a posterior polar. It was kind of a PSC cataract. IL power was plus 17 diopters, but I wanted to treat it like a posterior polar cataract. So here I went ahead and actually used the technique which is described by Dr. Vasawada, inside out technique, in which you go with the probe and then just create a little trench, and then you delineate it. That's called inside out, and the case becomes really simple and easy after this. So I treated it like a posterior polar cataract, and I was able to remove plate by plate in steps, and then I could emulsify it, and then the nuclear plate was removed, epinuclear plate was removed, and then the cortex was removed. But still I wanted to treat it like a PPC. That's why viscofluid exchange was done. I didn't want to risk it, that's why. This is the article which Vasawada sir has published. 46-year-old female patient, both eye vision 624, improving to 6.9 with pinhole, left eye grade 1 to 2 PSC cataract, IL power was 25.5. And in this I had tried everything, but it was not really working. So I had been to Dr. Saurabh Patwardhan's place this year, and he calls it this technique as dish technique, do it somehow. Because ultimately when nothing is working, you have to really keep your mind cool, and you have to keep your patience, and you have to complete the case. So this is how I was just trying to prolapse the nucleus with with chopper in one hand and the iris repositor in the other hand. I could prolapse it in the anterior chamber, and then I could emulsify it. So soft cataract, my pulse. Soft is harder. Accept it first of all. Do an appropriate size rexis. Use a good dispersive OVD, Viscoat in my case, like we use, to protect the endothelium, and good cohesive OVD, Helon, to protect the procedure capsule. Hydrodelineation is a must in soft cataracts. Have multiple techniques in your armamentarium. Always attempt chopping first, if possible with low parameters. Otherwise, if that doesn't happen, go to trench and divide. Hydroprolapse the nucleus, and if there's no shame in emulsifying the nucleus in the anterior chamber, if you have used a good OVD. Inside out can be attempted in only PPCs, but in my experience, it can also be done in soft cataracts. If nothing works in case of cheese wiring or ball formation, dish technique is something that I would go to. And last but not the least, keep patience, have patience, and it's not over until it's over. Thank you.
I think very nicely explained. Soft cataracts are harder than hard cataracts. One is you nicely pointed out the important points. Rexes should be slightly on the larger side, so that if nothing works out, you can prolapse the nucleus in the anterior chamber and do pupillary plane or supracapsular phacoemulsification. You just need to aspirate.
Yes, sir.
And not only hydrodelineation, which you rightly specified, even hydrodissection should be very good, so that nucleus should rotate.
Yes, sir.
If only hydrodelineation is there and hydrodissection is not proper, then it becomes very difficult, because you may be able to remove part of the nucleus, but the rest it
Greetings from my infirmary. Today we will present to you a case of senile
hydrodissection, and rest you should be adept at all the different techniques, so that if one technique doesn't work out, you can try, can make a small burrow and then try to chop, or you can do stop and chop, or if nothing works, do divide and conquer.
Yes, sir.
Even that can be done. Thank you.
Agreed, sir.
One thing I would like to make, like when using visco, sometimes we overfill it with it.
Correct.
So that is actually deterrent in phaco, because sometimes it
That blocks the, occludes the tip. Yeah.
it should be just minimal, just to coat the endothelium rather than
Overfilling.
Yes, sir.
As Dr. Bhalla rightly said, hydrodissection is important, so that the epinuclear plate will come out easily. Otherwise, the epinuclear plate, it is very hard to take out the epinuclear plate.
Thank you, sir. Thank you, ma'am.